Okay, we'll continue to talk about. Why don't you move over here? Then I'll, feel as if I'm being crowded. Okay, we'll continue talking about Chagas disease, that is American trypanosomiasis, or Trypanosoma cruzi. And we talked about the morphology and life cycle. Now we'll go over the symptoms. Just like African trypanosomiasis, the symptoms can be divided into several stages. The acute stage, or the primary lesion, is on the skin, of course, where the trematode, the vector, has bitten for a blood meal and left some of the fecal material there, and also organisms. And the organisms enter there, and in the skin the organism produces non-purulent edematous plaque and surrounding edema. That's a very important component of it. So, as I mentioned earlier, that the Ludovit bug or kissing bug, that's the reason. The reason it is called kissing bug, because it likes to crawl on the face, warm breath, and where it stings, and the smearing gets the organism in. And there will be a little lesion, and then there will be a lot of edema around it. And the whole complex of the lesion and edema is referred to as Romanas sign. And here's a typical characteristic edematous reaction here. Eye almost closing in. Okay, the acute stage, again, just like any other organism, when they get to the lymph node, there will be lymphadenopathy, and release of cytokines will cause other symptoms like malaise, restlessness, lymphadenitis because of the tenderness of the lymph nodes, hepatomegaly as there's a response to the invasion. There is splenomegaly, enlarged spleen, acute myocarditis. The organism has got a predilection for autonomic nervous system and nerves. And that among those organs included is the heart. So acute myocarditis will ensue, the infection during the acute stage, and there will be generalized edema as well, because the organism now is distributed all over the body. So those are the acute stage. Then a small percentage of these are sort of self-resolved, but a good proportion of them, they become chronic infections. And most of the time in infected areas, a lot of people present themselves with the complications of chronic complications due to chronic stage of the infection. And during this stage, the major symptoms are megaesophagus, enlargement of the esophagus, the autonomic nerves are destroyed, and the peristaltic movement is interfered with. There will be megacolon because of the accumulation of fecal material, because the peristalsis is not there, so they cannot really get rid of the fecal material. Cardiomegaly, enlargement of the heart, and cardiac arrhythmia. That's the major feature of the one of the major features of Chagas disease is cardiac arrhythmia, and often these individuals are presented to the physician for cardiac problems. Here is a picture, a toxic picture of megacolon, as you can see, it's enlarged. And here is another enlargement of the GI section. Megacardium, here's the picture of, and here's sort of on radiography, the heart is very enlarged. If one looks at the tissues, one finds the organisms as pseudocysts. Remember I mentioned to you that the organism in the tissue forms a pseudocyst where the organisms exist like a leishmanial stage of the organism. Pathology is direct inflammatory response due to the presence of organism. There is another toxin has also been described, referred to as Chaga toxin, and its effect is actually somewhat like lipopolysaccharide. And then damage to the infected cells, particularly of the autonomous nervous system neurons, destruction of those autonomic nerve ganglions, and that's why the peristalsis and the cardiac arrhythmia occurs. Okay, products of humoral immune response also lead to immune complex formation, and that will cause some damage, and then CMI too. Remember, the organisms can go inside the cell. As opposed to Trypanosoma brucei, this organism can survive and can grow inside macrophages, especially when they're not activated. They will internalize the organism and they'll support the growth. And consequence of that is, or response to that is cell-mediated immunity. Antibody, when it is produced, it kills, but not the eradicated cruzi because they can hide inside the cells. They become intracellular and they cannot be eradicated because of that. CMI, somewhat protective, has some protective value. And although there's no vaccine for it, but in experimental situations it's been shown that if one uses immunostimulants that activate macrophages, induces interferon, in turn activates macrophages, that one can, the infected mice at least, they can get rid of the organism. Activation, as I mentioned, macrophages. The general ARIA stimulation, general stimulation of the non-specific immune system. On one hand, it can lead to some killing of the organism, but if there are too many organisms, they cannot be gotten rid of easily. The ARIA stimulation leads to immunosuppression as well. So there is a secondary immunosuppression due to ARIA stimulation and presence of the organism. So those are the immunological features. Unlike Trypanosoma brucei, there is not a major role for changing antigenic code. Remember, variable surface glycoprotein I mentioned in context with Trypanosoma brucei. As the organism produces immune response, there is emergence of new clones that have got totally new variable surface glycoprotein, and the cycle goes on. There have been some very limited number of variable antigens described for Chagas disease as well, but not to the same extent as Trypanosoma brucei. So when you think of, or when you see variable surface glycoprotein, VSG, or changing antigenic code, think of Trypanosoma brucei rather than Trypanosoma cruzi. Diagnosis is based on history of travel to problem areas where in the bordering states to South America and Central America. There are often cases presented with cardiac problems, and the underlying cause is often the Trypanosoma cruzi. Ramana signs that I described, that the swelling around chagoma. Organisms in the chagoma exudate. The organisms can be found in the actual lesion, in the very, very acute stage, or in the lymph nodes. So lymph node aspirate can be taken to see to detect organism, or blood if there is a parasitemia. If the organism cannot, it's not a true picture of human blood, but it's sort of from a mouse that was infected in a bioassay, which I described for Trypanosoma brucei, which can be performed for Trypanosoma cruzi as well. One takes the small amount of blood from the infected individual, injects it into animals, most often mice, and those mice will get infected, and they very quickly develop parasitemia. And if you take mouse blood, one can see abundant number of these spindle-shaped, squiggly protozoa. Okay. The treatment is nifurtimox is in the acute stage, and then benzonidazole can of some value in chronic stage, but it is very difficult to treat once it enters the chronic stage. The control mechanism is avoiding the insects. Remember that the insect is not a flying insect. It can fly, but most often it's like palmetto bug, okay? That can fly, but very rarely it flies. But much smaller. Cone nose is the sort of specific feature. You've seen the picture of it. And one can avoid by taking the usual precautions. And the insect control by pesticide is a measure of control. There is no effective vaccine available at the moment. There are some efforts. It's a major parasitic disease in South America, so there are a lot of laboratories in those regions involved in developing developing vaccines. Okay, we'll move on to the next. Before we move on, the major comparison between brucei and cruzi is one causes sleeping sickness and tsetse fly is the vector. The other one causes jagomas and cardiac problems and sort of in the chronic stage. And that is Trypanosoma cruzi. One has surface glycoprotein, the other one does not. The Trypanosoma brucei survives the immune system because of having ability to change the antigenic coat, whereas the Trypanosoma brucei avoids the immune system by being internalized in the cells. So those are the major similarities and contrasts. In terms of morphology, they're identical. Okay, leishmaniasis. There are three different forms. The visceral, Leishmania donovani is the causative agent. You'll see it in the next slide. Cutaneous, Leishmania it will come to me. And then the other leishmanial form causes mucocutaneous, which is more common in South America. Tropica is the cutaneous and mucocutaneous. The Donovani causes visceral leishmaniasis, meaning of the hollow organs. So there's spleens are involved, the bone marrow is involved, the lymph nodes are also involved. It is probably the most dangerous of all three and is most predominant in Asia, particularly India. Afghanistan has visceral leishmaniasis, so our troops, there have been cases in our troops, in those who are in Afghanistan or have been there. You'll probably see later on as well, dogs are major reservoir for that. Leishmania tropica is the cutaneous form of leishmaniasis, common in Mediterranean area, northern part of Africa, Sudan, Ethiopia, as far south as that. And then there is Leishmania brasiliensis or Leishmania tropica with the name of the country attached to it. You may see some names. So Panamaniana or from Panama and Brasiliensis mexicana. You'll see a number of Leishmanial Leishmanial genuses there. We will talk about what is the difference in the diseases they produce. It has two different forms. One is promastigote form, where the flagellum is at the anterior end there, and the other one is the leishmanial form, a pear-shaped organism, and no prominent flagellum. Very sort of rudimentary flagellum. This form you do not have to worry about because it only exists in tissue culture or in the insect. So in humans or other mammalian hosts, you will only see this form, the leishmanial form. That's why the disease is referred to as leishmaniasis. Okay, amastigote in the human host, and promastigote, also referred to as leptomonad, is in the vector, that is sandfly. That is the vector for the life cycle is similar to other organisms that we have just talked about, from a vector to human. It's the vector in this case is the sandfly, and when it bites any human for blood meal, it transmits the organism. The organism, okay, here's the life cycle, and as I mentioned, dogs are the vector. And in the wild, the mosquitoes can also transmit. Not mosquito, I'm sorry, this is still sandfly. Sandfly is the vector. Okay, after the bite, there is a local reaction of the bite, but in the case of visceral, most of the time the organism very quickly spreads to the lymph nodes, and then from there to the blood and bone marrow, and there it will it will produce its symptoms. The characteristic feature is that there's not much of a local reaction at the bite site. Okay, except the sting that you feel. It's not like producing the chagoma, or in the case of African trypanosomiasis, a local lesion. Okay, lymphadenopathy is very common. Splenomegaly is a very characteristic feature. Enlargement of liver as well accompanies that. And during parasitemia, of course, there will be chills and fever. That's common to all of the organisms that produce parasitemia. One of the characteristic features is the darkening of the skin, probably because of hemolysis, some hemolysis. But darkening of the skin is a very characteristic feature of visceral leishmaniasis. For that reason, it's also referred to as black disease. Okay, there's a Hindi translation in your handout, Kala Azar, or that literally means black disease. As opposed to that, cutaneous leishmaniasis is confined to the skin, and there is a sort of centrifugally growing lesion as the lesion sort of produces micropapules around the central lesion, and as it spreads, the central lesions occurs, and there's some healings. The whole lesion can heal spontaneously, but it causes a very severe damage, very serious damage to the tissue, and leaves a permanent scar. You'll see some very disfiguring pictures of the scars produced by the organism. Mucocutaneous, it starts with a cutaneous lesion, but it spreads into mucoid tissues. Okay, the skin and mucoid tissue are the target, initially same as cutaneous leishmaniasis, but it does not heal, and the necrosis of mucoid tissue occurs, and the organism metastasizes to distant mucoid tissues, and it is very, very disfiguring. I think I've got some pictures of that. If I have hidden them, I'll get to them in the break, and we'll go over that. The visceral leishmaniasis, 1 to 4 months, the fever, chills, diarrhea, dysentery, and progressive hepatomegaly. And if it is not treated, it is usually fatal. Skin hyperpigmentation, as I mentioned earlier. So that and here is a sort of severe instance of splenomegaly, hepatomegaly, and then spleen can be palpated as well. And you can see sort of darkening of the skin. And illness, of course, will result in malnutrition as well as weight loss. Yes?
Are those lights showing that the liver was all
Yeah. Yeah, gross splenomegaly. That's one of the very characteristic features of that. And here's the case that was reported. Patient A, fever of 102 was first noted in a patient by patient A. There were 2 patients actually reported in that communication in late December 2003, and rigor, flushing, sweat, and mild orthostasis in early January 2004. Lost 13 pounds of body weight. Visceral leishmaniasis was suspected, but no leishmanial parasites were noted. On light microscopic examination or culture of bone marrow and liver biopsy specimens, so it was difficult to isolate the organism. And no leishmanial DNA was detected by genus-specific polymerase chain reaction. Analysis of the bone marrow PCR analysis of bone marrow specimen. The findings in the splenic enlargement suggested and surgical splenectomy was considered. In February 2004, because of continuing concern that the patient had visceral leishmaniasis, based on history, of course, the liver biopsy specimen was re-examined by light microscopy. 1 definite and multiple probable leishmanial parasites were detected. So early on, it was difficult to find any organism, and if I remember, this was one of the soldiers from Afghanistan. The accompanying patient B, the abrupt onset of fever 104, same symptoms as one before, symptoms worsened, and there was anorexia with a loss of 25 pounds. During the next 6 months. No leishmanial parasites were found on light microscopic examination of bone marrow and Buffy-coat specimen, but were prevalent in liver biopsy specimens. So one can take and see the organisms in the enlarged liver. During February 2004, patient was treated with lipid formulation of amphotericin B. That's an anti-mycotic drug. You'll hear more about it from Dr. DeSalvo when he comes to talk to you. But for some reason, it was thought it would be effective in this as well, resulting in a transient improvement of symptoms. He was rehospitalized in March with a temperature of 102. Results of PCR analysis indicated Leishmania donovani, that is visceral leishmaniasis, of course. On March 19, a 28-day course of anti-leishmanial therapy, Pendosam. That's the standard treatment for leishmaniasis. It's an antimonial compound. It was administered. Okay. Let's see what the result was. I don't remember what the result was. I think it was successfully treated. And here are the examples of cutaneous leishmaniasis. You can see the encrusting and then micropapules around it. More obvious here. Okay, disfiguring scars. Not life-threatening, not like visceral leishmaniasis. So, the cutaneous is much milder form, although it is disfiguring. Here's more diffuse, sort of. There is a. It can happen in immunosuppressed individuals, immunocompromised individuals, the diffuse spreading of the lesions. But for some reason, Ethiopia, in Ethiopia and Sudan, that area, Northern Africa area, there is a variety of leishmania that can cause this disease, even in immunocompetent individuals. Okay, mucocutaneous, as I said, that it affects the mucoid organs, and you can see the dissolution of the bridge bone and the severe disfiguration here, and this is also mucocutaneous, a little bit more diffuse. Diagnosis is based on history. Again and again, I can emphasize and re-emphasize the history is important, where the person has been, and that will make you think of the organism, and then it can be confirmed by isolating the organism. The organism can also be grown in tissue culture. Lesion, presence of lesion, local lesion, or in the case of visceral, there's no lesion, so you've got to rely on biopsies and other symptoms. The organism can be found in the local lesion in the case of mucocutaneous or cutaneous, and in the bone marrow smear or the liver biopsy in the case of visceral leishmaniasis. Okay, here's sort of a bone marrow preparation with phagocytic cells infected with many leishmanial forms of the organism. Here's another one from tissue culture where they are outside the cells as well as inside the cells. They are intracellular as well as extracellular. Okay, there is a skin test available. It's referred to as Montenegro test, and it's intracellular organism, therefore there will be delayed hypersensitivity, so it will be type 4 hypersensitivity to a preparation from leishmania that's referred to as leishmanin, like tuberculin from tuberculosis, leishmanin from leishmania organism. It's called Montenegro test, and I have been told by Dr. Noctegal, who is Romanian, that it's a city in Romania, and that's where the test was named. Test was developed, I guess, and that's why it's referred to as Montenegro test. Okay, pathogenesis and immunology, damage due to CMI. So that's one disease where type 4 hypersensitivity is the major cause of damage to tissues and organs. There is a proteoglycan molecule that can also cause inflammation. Leukopenia with monocytosis and lymphocytosis, it will be seen in the blood in CBC. There is accompanying immunosuppression during the infection, just like in Trypanosoma cruzi and even Trypanosoma brucei. Interferon and TNF both are protective, and there has been a lot of work in mouse models. The organism can easily infect mice, and they can be protected by treatment with interferon and TNF. So a general immunostimulation would be helpful in fighting off the infection. No vaccine again. I'll keep on telling you probably throughout the parasitology course, there are no effective vaccines against any of the parasites. Control measure is control of the vector. And getting rid of these stray dogs. Unfortunately, in that part of the world, there are lots and lots of stray dogs that are reservoir for leishmaniasis. Avoidance of sandfly for people, but then when there are troops there around, they can't be sitting in mosquito nets. They've got to be in the open area, and they are exposed to, or they are open to biting by the flies. Pentasam, antimony leuconate, is the chemical nature of the therapeutic agent. Okay, so those were leishmania. And as you said, you can see that morphologically they have similarity and causing different diseases. Okay, next we will tackle malaria. That is probably the widest and most frequent infection, both in the tropics and subtropics. There are 4 different organisms, separate species, separate genera of these: the Plasmodium species, Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae are the 4 malaria-causing agents. As you will notice later, that Plasmodium falciparum is most serious of the 4 malarial parasites. Geographic distribution is almost worldwide, particularly in the tropics. You see nothing there, but I'll show you a few cases that there have been indigenous cases of malaria in Texas, as well as far north as Virginia.